Hello and welcome to the ACHD Hive Talks. My name is Dr. Bouchard. I'm the founder of the ACHD Hive. And today, for the fourth episode of the Cardio-Obstetrics series, we're honored to have Professor Ladouceur and Dr. Valdeolmillos, who will start this session by presenting pulmonary hypertension in pregnancy. And then we're very, very pleased to have with us Dr. Martin de Miguel, who will be our panelist. And we will then follow the presentation with discussions. We welcome questions in the chat, or if you want to raise a virtual hand to ask any questions, are welcome. And so with no further ado, we will start our presentation on pulmonary hypertension in pregnancy.
Yes, it's okay. Okay. So thank you so much, Melissa. We're going to start with a clinical case. It's a 24-year-old woman with an irregular follow-up of Eisenmenger syndrome, secondary to a complex congenital heart disease with consistent and multiple ventricular septal defects, straddling EV valve, and also atrial septal defect. At the age of 2, she had a pulmonary banding in Algeria. It was complicated with a complete AV block, which is treated with an epicardial pacemaker. At the age of 11, she has a hemodynamic evaluation. As you can see, she had a severe pulmonary arterial hypertension and no specific treatment history for this patient. So she presented at the consultation for dyspnea at 5 weeks gestation with a desire to continue the pregnancy.
No. Sorry, Melissa, can I change the PowerPoint because I mixed. I'm very sorry.
No problem. No problem.
Thank you. Yes. So, can you see my screen still?
Nope, you stopped sharing.
Okay, okay.
Okay.
Okay. Yes. Sorry. Okay.
Really sorry.
As I said, this patient presented at consultation for dyspnea at 15 weeks of gestation with a desire to continue the pregnancy. So the examination, she had an overweight, blood oxygen was 90%. She had no signs of right heart failure, but at this moment, she was in functional class 3, reflecting a moderate to severe functional limitation. The electrocardiogram was normal with no arrhythmias. And at the echography, we can see multiple ventricular septal defects with right to left shunts, and also a moderate right ventricular dysfunction. Left function was normal. So the PH prognostic factor in pregnancy are, as you know, the Eisenmenger syndrome represents the highest risk of maternal mortality among other causes of pulmonary hypertension. Also, other risk factors include blood oxygen desaturation, signs of right heart failure, and other complications like thrombotic or hemorrhagic complications. Also, for the risk, important is the right ventricular dysfunction, as we can see in this patient. So, as we do with all the type of this kind of patients, we had our multidisciplinarity discussion in our PH reference center. So the conclusion was that the pregnancy was strongly discouraged, but the patient expressed her desire to continue the pregnancy. So we proposed, as we do for all these patients, a pre-transplant evaluation after a multidisciplinary discussion. Also, close follow-up every 2 to 4 weeks with different exams like echography, 6-minute walking test, and other biological marker. Hospitalization during the third trimester, and also we're going to plan the delivery between the 28 and 34 weeks gestation, depending on the clinical status. So the pre-transplant evaluation in these patients at 17 weeks gestation, as I said, she was on severe to moderate functional class limitation with a low NT-proBNP, no renal dysfunction, no other major irregularities in the biological markers. Functional pulmonary function tests were normal. However, 6-minute walking test was low with 300 meters and also an important saturation of 62%. Indicating the very dismissed exercise capacity in this patient. The other exam were normal for the pre-transplant evaluation. So the decision at this moment was to introduce monotherapy treatment with sildenafil. We are going to do also the preventive anticoagulation, always with low molecular weight heparin. Also, we are going to start excision therapy and close follow-up, as I said, to every 2 to 4 weeks. And cesarean section is going to be planned between the 34 weeks of pregnancy, depending on the evaluation. For all these type of patient, we are going to create an action plan for how to handle the patient care in case of right ventricular heart failure with need ECMO or bridge to recovery or to transplant, depending on the cases. So yes, a few words for the treatment because Magalie is going to talk later. We have different treatment. We have to know that the treatment, the endothelin receptor antagonists are teratogenic and contraindicated. We can introduce or continue the prostacyclin therapies. A thromboprophylaxis is no universal consensus, and we have to do with low molecular weight heparin. And as we do here in our center, we continue the prophylactic anticoagulation after 6 weeks postpartum. And oxygen therapies, according to maternal tolerance, is also for improving fetal oxygenation. So the follow-up in this patient was stable with no other complication. The serial echocardiographic exam were stable with moderate right ventricular dysfunction. NT-proBNP was stable around 400, and the discussion of our multidisciplinary team was to plan the cesarean section at 30 weeks under regional anesthesia. And ECMO team is going to be available on site, only bridge to recovery, because in this case, the patient was contraindicated to heart-lung transplantation due to psychological and social issues. So a little bit of the perioperative management of these patients. So we should avoid general anesthesia because the high mortality. Also, mechanical ventilation may worsen the hemodynamics in these patients. So the titrate epidural anesthesia is the preferred approach. Also, avoid single-shot spinal anesthesia because it's a risk of sudden hypotension with severe hypoxemia. And always, we have to have our ECMO team available on site. As I said. So for the mode of delivery, optimal timing remains uncertain, but it is often around 34 weeks stations. We're going to talk about later. My elective cesarean section is preferred in several centers, but the vaginal delivery could be considered most in very low risk patients. That's how we do in our center, but Magalie is going to talk about later about disease. So for this patient, as I said, she was hospitalized in the intensive care unit in around 34 weeks of gestation. We continue excision therapy and we prepare for the delivery the patient with the installation of catheter, central venous catheter and arterial line. We prepare also the diuretics and very low dose of noradrenaline and the glutamine and pendin. So this patient has a cesarean section at 34 weeks gestation with no incident under regional anesthesia. She has a moderate dose of noradrenaline, also NO and high flow nasal oxygen. And the newborn was born without complication, with good adaptation. He was a fetal growth restriction with 1,600 grams for 34 weeks. So it's wow. So the postpartum follow-up was stable for this patient. We changed the sildenafil for tadalafil and we add ambrisentan. We continue the prophylactic, the preventive anticoagulation for 6 weeks postpartum, and the evaluation 4 months after the delivery was okay, with an improvement in the functional class, with an epicural peak was stable, with also an improvement in the 6-minute walking distance for this patient. And the right heart catheterization showed severe pulmonary arterial hypertension, but with a preserved cardiac death. So this patient is still on dual therapy and is categorized on low intermediate risk according to the latest guidelines of pulmonary hypertension.
Thank you, Estíbaliz. Then we move on to the second part, and the purpose of the second part is to show you some studies that support the previous management concerning PH in pregnancy. The first things to say is that the number of patients with PH who delivered is quite high, considering this very risky condition. And this was observed in this population-based study from US that included more than 1,500 patients who delivered and who had a diagnosis of pulmonary hypertension. Most of them had isolated PH, but there was also patients with left-sided heart disease and PH. And we will see that not all of these patients had the same prognosis, and this may depend on the underlying etiology of pulmonary hypertension. It's important also to remember principles for physiology in pregnancy and PH. In PH, the pulmonary circulation is unable to accommodate increased blood volumes and pulmonary blood flow that occur during pregnancy. As a result, the right ventricle faces a major increase in afterload, and RV adaptation is therefore crucial to maintain normal cardiac output for the pregnancy. However, in advanced disease, these adaptations became maladaptive, and the right ventricle start to dilate. The myocardial oxygen demand may increase, and also there may have some ischemia, particularly due to the decrease in systemic vascular resistance and impotation, which is usual in pregnancy. Also, arrhythmia may further compromise the cardiac output and precipitate decompensation. The highest risk occur during the perinatal period, just before delivery and just after delivery, when abrupt volume shifts and may trigger acute RV failure. Pregnancy also increased thromboembolic risk, which leads to a severe increase in afterload and may lead to cardiogenic shock. And at the extreme end of the spectrum, as it was previously presented, Eisenmenger syndrome is a very severe condition specifically in PH, and the cyanosis may worsen due to the increase in right to left shunt due to a decrease in systemic vascular resistance, and this may lead to a bad tolerance in the mother as well as the fetus. Clinical presentation may be cardiogenic shock, as I said, but also patients may have symptoms that mimic normal pregnancy, and it's sometimes quite difficult to determine the tolerance of the patient and the evolution of the disease under pregnant state. Patients may have leg swelling or breathlessness or ascites, which may be difficult to diagnose in patients who are pregnant. And it means that this needs some experience in evaluation of pregnant patients and PH. Women can also complain from chest pain or syncope, and it's very severe symptoms. We have to look for signs of PH, like loud pulmonary component at second heart sound, or also RV failure signs with raised jugular venous pressure, right-sided third sound, signs of tricuspid regurgitation, and arrhythmias should be screened at each evaluation. But we should remember that this may be confused with symptoms and signs of normal pregnancy, and this needs a deep evaluation of the patient. Concerning risk assessment, it was well illustrated in the previous case. The group 1 is still at high risk of mortality. Even if there is a decrease in mortality rate, it remains prohibitively high, between 12 to 17% of death in the most recent study. Causes of death are due to RV failure, cardiac arrest, PH crisis, preeclampsia, and sepsis, and is mainly postpartum complications. As a consequence, pregnancy is still strongly discouraged, and termination should be indicated, and this is the recommendation from the recent ESC guidelines, and all patients with PH are considered modified group class 4. Among risk factors, when you have to discuss the risk with the patient, there are some red flags which are shown here in the red part. Patients with a very severe disease of PH, illustrated by high pulmonary hypertension, low oxygen saturation, high BNP level of pericardial effusion, obviously may experience complications and are at risk of mortality during pregnancy and during the postpartum period. Also, patients who were delivered under general anesthesia have a fourfold higher risk of death. Then it's not the option when the obstetrician decide with you the option of delivery with the anesthesiologist. But there is some less severe factors, and this is in yellow, and can be considered as lower risk profile, notably stable patients with low functional class, and those well controlled with calcium blocker therapy. And we will discuss disease group later. Still in the group 1, CHD associated with PH and other group in CHD were well explored by the largest study of CHD and pulmonary hypertension in pregnancy from China. These studies include 721 women, and 619 had CHD and PH. And maternal cardiac events increased with the severity of pulmonary hypertension, as is shown on the graph in the left side of the slide. The highest risk was observed in Eisenmenger syndrome, followed by repair defect and left to right shunt. Importantly, a multidisciplinary management and structure antenatal care were protective factors which illustrates the important place of the pregnancy heart team in the management of these very severe patients. What about the patients with pulmonary hypertension from group 2? And I come back to the previous study using medical administrative data from US. They show that PH is associated with left heart disease, experience substantially higher major adverse cardiac events, mainly driven by heart failure and arrhythmia, compared to other etiology of pulmonary hypertension. Moreover, they show that patients also had higher rates, but it's the case for all pulmonary hypertension, but they had higher rates of eclampsia and prematurity and fetal death, which highlights the importance of information and discussion with the patients who want to become pregnant. What about favorable pregnancy outcome in very selected patients? These patients are those with mild or well-controlled pulmonary arterial hypertension, and results are from very small series of less than 20 patients. But it seems like patients with NYHA class 1, 2, or with low pH, low risk profiles from the ERS and ESC stratification, or those with a good response to calcium channel blockers therapy may have a good outcome and had successful deliveries without major complications in PH expert center with an experienced pregnancy heart team, as it was observed in the previous case. And this concerns very selected patients and need all the expertise in PH and pregnancy to allow this patient to become pregnant if they have in the green zone. To conclude, for this part, pregnancy are still at high risk and are considered as a modified WHO class 4, requiring expert counseling by pregnancy heart team. And in case of pregnancy, termination should be discussed in a shared decision-making process. Some pregnancy may be manageable in very selected patients and are those with well-controlled pH and mild level of pH. And women who choose to continue must immediately be referred to expert patient center and managed by MDT multidisciplinary team. What about pregnancy? Again, pregnancy heart team has a very important role in the management. This team should include PH specialists, cardiologists, high-risk obstetricians, anesthesists, and neonatologists, and as it was shown previously, also team members from the lung, heart and lung transplantation. Studies have shown that multidisciplinary approach in this situation is associated with a reduction in urgent C-section, lower rate of heart failure incidence, and a lower maternal mortality, but also good outcome concerning the babies. During pregnancy, the assessment should be regularly performed, at least each 4 weeks up to the end of the second trimester, and during the first trimester it can be each week. It depends also on the tolerance of the patients. It's important to provide at the beginning of the follow-up a detailed pregnancy care plan. Patients with irritable pH should have genetic counseling. Right heart catheterization should be performed before pregnancy, but it can be also performed during pregnancy if there is not a clear diagnosis of PH or the severity of PH, or if the patient has some clinical deterioration. And concerning the regular evaluation, each evaluation should include symptoms evaluation, echocardiography, as it was showed, to evaluate RV tolerance and serial NT-proBNP that can help in the decision when the patient is more and more decomposed. Concerning treatment, as it was said, the first treatment is rest, and if it's not possible at home, hospitalization may be required. Oxygen can be therapy to improve symptoms in the woman as well outcome for the babies. Right heart failure should be promptly treated using diuretics with a regular control of amniotic liquid with the obstetricians. And if it's not effective, termination should be discussed with the patients. As it was shown previously, anticoagulation therapy need to be balanced between the risk of bleeding, which is higher in this group of patients, specifically during the delivery. But in case of patients who were previously treated by anticoagulation, usually anticoagulation is continued and is continued using heparin. Iron deficiency also should be screened and treated if there is iron deficiency, specifically in cyanotic patients. And targeted therapy should be continued or initiate early in the pregnancy, but not whole targeted therapy. Because endothelin receptor antagonists have a teratogenic effect, then they should be switched to PDE inhibitors, mostly sildenafil. We have less data about tadalafil. And in case of severe PH, iloprost can be prescribed during pregnancy. And during breastfeeding, sildenafil can be continued as well as iloprost. There are some evidence or at least data to support this management because studies show that starting targeted therapy only during the peripartum period is associated with significant higher maternal mortality compared to women who were already treated earlier in the pregnancy. And in very severe PH and more severe, early combination therapy, such as sildenafil and the prostacyclin analog, may be considered to reduce the pulmonary vascular resistance and improve RV function. Obstetric complications are also important to know, and there are in this group of patients surprisingly a high rate of obstetric complication, mainly hypertensive disorders such as preeclampsia or gravid hypertension that occur in about 2 to 12% and are related to a worse outcome with a higher risk of death. Often it is occurrence of hypertensive disorder are related to disease severity, probably due to impaired uteroplacental perfusion and then consequence for the fetus. Postpartum complications are also frequent, and particularly hemorrhage, as I said, and infection, and most of disease complications are related to C-section, which is reported in about 50 to 70% of pregnancy due to therapeutic indication for patients with PH. Concerning delivery and postpartum, as it was well illustrated in the case, a planned early delivery is mandatory between 34 or 46 weeks of gestation, but this depends on maternal tolerance as well as fetal growth. The optimal mode of delivery is usually by cesarean section because it can be performed in a controlled environment, while vaginal delivery can lead to a prolonged labor or vasovagal maneuver that may be badly related on pH hemodynamic. Also, in case of induction of labor, it's important to use with caution oxytocin due to risk of tachycardia reflex and decrease in systemic pressure. Anesthesia, as it was shown, should be titrated using epidural or spinal anesthesia to avoid a deep decrease in systemic vascular resistance that can be badly related in patients with PH or increase the oxygen desaturation in case of Eisenmenger syndrome. And in some centers, it's proposed to treat by epoprostenol just before and just after delivery to improve the control of hemodynamic in this very crucial step for the pregnancy. Postpartum period, as it was said, is a very critical period. Most of death occurred within the 2 weeks following the delivery and up to 6 months, but the 2 first weeks are very, very crucial. It's why it's important to transfer the patient in the intensive care unit to be monitored. The aims of the treatment will be, as it was observed in the previous case, to reduce the risk of RV failure using advanced PH therapy, inotropes, to prevent bleeding versus prevent thromboembolism complication. And this is case by case discussed. And also provide aggressive diuretics within at least the first 7 hours following the delivery. After discharge, it's important to early see the patients within the first week following the discharge or no more than 50 days, because it's the moment where the woman can have a severe heart failure and she be at risk of death. Then it's important to following this to have regular clinical evaluation, echocardiographic evaluation, as well as BNP measurements. What about baby? It's important also to discuss it with the parents if they are hesitating about the pregnancy purpose. Babies have a very important rate of morbidity, and it's deeply related to the PH severity. The first complication is miscarriage or stillbirth, but the major complication is the prematurity that can occur up to 78% of pregnancies, mainly in patients with chronic cyanosis like Eisenmenger syndrome. There is also a risk of small gestational for age and the risk of recurrence or irritable PH, and this should be discussed with the parents. And finally, the mortality is about 1%, which is higher than in the general population. Then it's important that the obstetrician plan a regular ultrasound for fetal growth and fluid assessment, particularly in case of treatment by diuretics. And also it's important to have on the site an advanced neonatal intensive care facilities to optimize the outcome in the newborn. What about elective termination? Elective termination is an option, but it should be indicated before the beginning of the second trimester, because after this delay, the risk is the same than for a complete pregnancy. This termination should be performed in an expert center of PH with all the facilities to manage decompensation with cardiologist, intensivist, and if necessary, surgeon. It is the patient's needs for ECMO implantation. And there was cases with this type of scenario. And also, which is important, is to provide adequate psychological support because it can be very stressful for the woman. Finally, contraception is very important since it's a pregnancy at very high risk. Progesterone-only pills are preferred, but in patients under androgen receptor antagonist, their efficacy is decreased, and it is recommended to use a second mode of contraception, like condom, for example. Combined estrogen-containing contraception should usually be avoided because it increases the risk of arterial and venous thromboembolism. Long-acting reversible contraception, such as intrauterine devices, is a good option that should be implanted in a center where there is a PH specialist in case of vasovagal reaction, which can be badly correlated in women with PH. And finally, permanent contraception can be discussed if the patient delivered by C-section, but also can be discussed out of this scenario. And the other option is a male sterilization, which is seriously the optimal mode of contraception, but it's quite difficult to discuss with the couple. To conclude, pregnancy in PH remains very risky, and prevention and counseling are essential. In very selected patients, outcome may be favorable, but this is determined by PH experts who follow these patients. And all disease results are possible if the patient is managed by a pregnancy heart team. Thank you.
Thank you both. You have a message of congratulations from Alexandra in the chat. So congratulations.
Thank you, Alexandra.
So we welcome any comments or any questions, either in the chat or if you can raise a virtual hand. Irene, have you got any questions or observations to share?
Yes. Yes. So thank you very much for both of you. The presentation was great. The case is very interesting, and the comprehensive review was, like, I think, important for everyone in the audience to more or less know what we are talking about. And thank you also to Melissa for organizing these talks. They're really excellent, and I really recommend the participants to look at the other ones because they're very good. So talking about your case, you presented a very challenging case of an Eisenmenger syndrome, which actually I think it's the patients who have maybe the worst prognosis or the highest risk when undergoing a pregnancy from PAH. Your patient had a very good outcome in the end. And I would maybe like that you explain the audience, or that how would you have proceeded if the patient would have deteriorated? Would you have, like, for example, initiated hydropros or rather prostacyclins? Or what are the signs that you look for in your patient, specifically in a patient with Eisenmenger syndrome, to know, okay, this patient isn't going well, we might have to increase the treatment?
Yes, as I said, here we have the opportunity of heart lung transplantation. For all these patients, we are going to do a pre-transplant evaluation when it's possible. So as I said, we did that for this patient. And also we are going to do a close follow-up every 2 to 4 weeks. And it depends on the evolution. We're going to up the treatment with prostacyclin if it's needed. And it depends on the patient. As I said, we're going to do we are going to create a plan to act in case of right ventricle failure for these patients. So they are like really close follow-up, and we are going to decide before the right heart failure if we are going to assist with ECMO to reach to recovery, or ECMO to reach to transplantation if needed. So it depends of every case, each case.
If I can add, in the literature, there are some cases with inhalated iloprost in Eisenmenger syndrome, and it's true that if the second line after oral pH therapy, if the patient seems to have some bad tolerance, and it's true that we should also recommend a close follow-up in case of worse symptoms, and to discuss promptly with the heart transplantation team as well as the ECMO team according to the evolution.
Yes, and I think in these specific patients, like for example, what we usually do in PH patients when we have a female with idiopathic or heritable hypertension that gets pregnant, what we usually do is when they stay on monotherapy with sildenafil or tadalafil, and when they get worse, what we usually initiate is first epoprostenol, IV epoprostenol at low doses. That usually happens during the second and the third trimester when it gets more challenging for the patient. And we usually get them through the pregnancy with that dual therapy, sildenafil and epoprostenol. But for example, Eisenmenger patients, if you put them on epoprostenol, they can, like, systemic blood pressure can get lower, and then that could lead to maybe more right to left shunting and more desaturation. So in this specific cohort of patients, as you said, Magalie, it may be more reasonable to start them on iloprost, which does not produce systemic hypotension, and might be better in the specific case of patients. We usually reserve iloprost for Eisenmenger patients because, and then the rest of the patients, as we said, we put them on epoprostenol, IV epoprostenol. Mainly, I would say also because iloprost, it's also it's a lot of effort to do. You have to do that 6 times a day, and inhalations are tough to do, like 20 minutes each time. So yes, and because epoprostenol is very simple to manage. Half-life is 6 minutes, so if something worse happens, you can stop the medication, and that's it. And it helps us also like titrate slowly, depending on how the pregnancy goes. Like to start it on the second trimester at maybe 6 nanogram kilogram minute and then titrate it during pregnancy if the patient get worse. But I think Eisenmenger patients are more challenging in this case because of the shunt, and to take that into consideration.
Yes, and they have the worst pregnancies.
Yes.
Worse.
And you also mentioned what is very interesting in them, the thing with anticoagulation, because as we know, they have increased bleeding, but also increased thrombotic risk, and also they have the risk for paradoxical emboli. So, but many times they have low platelet count, so you don't know if it's better or not to put them on prophylactic low molecular weight heparin.
It's important to sensitize anesthesiologists about the right to left shunt. Usually they know because they are experienced people working with us and managing our patient with cyanotic disease. But it's important to remember that patients should have filter on the perfusion to avoid bubble and the risk of right to left embolism.
Mm-hmm. Yes.
About the anesthetist, I was just going to make a comment or a question. She had a C-section under epidural, is that correct? Or under GA. I think that I can you just clarify what would be the benefits or risks for both GA and epidural, and how would you choose which would be best?
Virginia is still there.
Okay. So we are going to avoid general anesthesia and all these kind of patients. That's our way to do it. So the general anesthesia has a high risk of hypotension, also mechanical ventilation. It's going to worsen hemodynamics in these patients. So we are going to choose a titrated spinal or a peridural anesthesia. avoiding shots of anesthesia, because also this is going to produce high risk of hypotension, and in Eisenmenger syndrome is a very risk of severe hypoxemia for our patient. So the indication, the anesthesia indication in this patient is titrated spinal or epidural anesthesia.
And also, Melissa, when you have mechanical respiratory support, this increases in the pulmonary vascular resistance and can lead to increasing RV afterload and lead to heart failure. It's why it should be avoided in case of PH when there are indications for delivery.
So in our center, for example, we are in general very restrictive with mechanical ventilation in PH in other settings. But for C-section, our anesthesia team, they prefer to do general anesthesia. And it's something like they feel more comfortable with that. They say they don't control hemodynamics as well with epidural anesthesia. And I think we, of course, the anesthesiologists that take part in these surgeries are cardiac surgery anesthesia. And I think because they're used to these patients, because we do like many, for example, pulmonary endarterectomies in pulmonary thromboembolic hypertension, they know the risk of these patients from mechanical ventilation, and they do prefer to do C-section with general anesthesia than epidural. But I think what they said is correct. In general, mechanical ventilation should be avoided in these patients, but in the end, it all gets summarized that anesthesia is comfortable with your patient and what they prefer in this scenario. Yes.
They do this even in very severe PH.
Yes, they have done it. Yes. Yes. I think they just, because, like, for example, when we because they might be used to it, because as I said, pulmonary thromboembolic hypertension that go to the OR to do pulmonary endarterectomy, so group 4 PH, sometimes they're also really, really sick with very late pulmonary pressures, and they're more or less used to ventilating them, and that's the reason. But I'm not saying it's better than epidural anesthesia. It's just what our team does, because I don't know, they're used to that and they feel more comfortable that way. Yes.
I would say it's a little bit difficult. It's a little bit different with the Eisenmenger syndrome, because like general anesthesia in Eisenmenger syndrome is not well tolerated at all.
Yes.
We have
Yes.
So is the hypoxemia, a severe hypoxemia with the risk. So Eisenmenger, I think it must be a little bit different. And general anesthesia, I don't know if you do also in Eisenmenger syndrome the general anesthesia.
So of that, I know we had an Eisenmenger patient, but I didn't work here yet, so I'm not sure what they did. But in general, they do like to go that way. But like I said, I think the most important thing is that your anesthesia team feels comfortable, that everyone is on the same page, and that the patient goes correctly. Yes. So maybe another question, like because you mentioned it during your presentation also, do you differentiate in your management and delivery plan between patients who are responders to calcium channel blockers to those who are non-responders?
Yes, clearly patients who are responder to calcium blocker had better outcome, and most of series show the delivery when it's managed by PH experts have no complications. Then this should be checked by invasive right or catheterization to be sure that the pressure, the pulmonary vascular resistance is controlled under these treatments. But it's true that in these selected patients, it may be a possibility. I put some caution, because it is always we should inform the patients about the risk as well as the evolution of PH after pregnancy. We have no idea about the long-term outcome and the impact on this outcome related to pregnancy. Then it's a possibility, but it's a shared decision making with the patients, and provided by experts in PH.
Yes, I do agree. I think it's important, like you said, to know that they're really responders. And another important thing, maybe it's like that they do not interrupt the treatment, even not during delivery, because that's when it can get very, very bad. You know, you decide vaginal delivery and they're going through induction, and this takes 12 hours or 24 hours because it's the first pregnancy. And then the anesthesia team forgets the amlodipine, like the calcium channel blocker dose, and that is when it's going to get very bad because they're going to have the pulmonary hypertension crisis. And then, yes, so I think one of the things that we like repeat the whole time is like, do not stop or do not forget any dose of the calcium channel blocker, because that is what can make it worse. But I would say with these patients, we can be more flexible and also like terminate program delivery later. Like maybe we can even wait in these patients if they're well controlled till the 38th week or 39th week, and avoid the complications of preterm delivery for the neonate, because they might tolerate it.
Yeah, you're right. It's true. It should be discussed case by case. If the pH is well controlled, the patient is under treatment. It's the delivery is evaluated very well, and the obstetrician sometimes says the first stage and the second stage will be very easy, and the timing of labor will be short. It is a good option to such management. Yeah.
I have a question about BNP, and we've spoken about BNPs in previous episodes. So you measure the BNP in your clinics. If you'd seen that had been a big jump, and I suppose you correlate that with clinical signs, but for that patient, she was lucky, I suppose it went well. But in that patient, what would have been the red flags for the audience? Yeah, where you start thinking, we probably need to induce soon.
So I could say right heart signs of right heart failure. For me, this is a red flag. Also, the echography. If you say if you see that right ventricular dysfunction is degrading, pericardial effusion is really important. Also, the augmentation of anti-BNP and
is there a cutoff of anti-BNP? I don't think so. Do you have any here, Irene?
No, I would say it's more like the tendency, and like Melissa said, correlating with the rest of the data. And as you said, like for example, in an Eisenmenger patient, that he desaturates more during 6-minute walk test or just coming to the clinic basal. So yes, thinking he's shunting more right to left, and hemodynamics are worsening.
Mm-hmm.
Yes.
And of course,
I
like
think
right failure.
Her 6 minutes in the end, I think her 6 minutes was pretty awful, wasn't it? Towards the end.
Yes, it was 300 meters. Yes,
300 meters.
And she had RV dysfunction, I think, before even starting.
Yes.
So how do you it's difficult to know, how do you quantify when's the cutoff? Her LV was holding up, but once you get to...
Yes. No, it's really difficult. We propose determination of the gestation, but the patient, she expressed that she wanted to continue. So...
Yeah, and I think that's really important, and you've shown that through the both of your presentations, that the discussion and the communication with the team and with the patient is so crucial, because ultimately we can, as doctors and expert, advise her these are the risks, but she decides, and it must be very difficult if you're in a situation where you know that there's such high risk for both the baby and her. How to communicate that, I think, requires a lot of skill, and I think we're learning now. I think back, if we look at the guidelines previously, I think they were a bit more stern and a bit more...
Yes.
Now we are very much more patient focused.
Yes.
But which is important also, it's to adjust our the communication about risk. It's very individualized evaluation and communication with the patients. And in case of a woman with very severe condition, like the case presented by Tibalis, personally, I have some experience when I clearly explain the therapeutic plan. It means that maybe at the end of during the delivery, you can be assisted with ECMO. And if it doesn't work, you can be emergently transplanted if there is a graft for you. If you are very clear, transparent with the possible evolution, sometimes women realize how it is complicated, but it depends on the understanding of the patients.
Yes, and also another important thing is what happens after pregnancy, because it is uncertain whether PH can progress more rapidly after pregnancy. If pregnancy is like an accelerating factor, so that it accelerates the curve of pulmonary hypertension, or whether, for example, calcium channel responders, they lose their responsiveness and they turn into non-responders. So this also has to be discussed with the patient, that it is uncertain, we don't know about it, but that it might happen. And it's also important because they're like what Lorna was saying in the talk of Fontaine, in pregnancy, they're going to be mothers, and like the child gets, like they have to be there for the child when the child gets older.
That's why it's important to discuss with the husband too.
Yes.
Mm-hmm. I think that was a really important point, that we've never talked really about male sterilization as an option for the couple.
Yes.
Yeah.
Yes.
Or counseling usually should be performed with the couple, not only with the woman. But it depends on the situation of the couple, but most of the time it's important to see both.
Just in terms of this lady, how long did she stay in hospital after delivery, and what's normal? I know these cases are very
normally this kind of patients going to be hospitalized between 3 and 4 weeks if everything is okay. So this woman, I think she was hospitalized for 1 month after the delivery. So yes,
without a baby.
Without the baby, yes, without the baby, because the baby is in the neonatal intensive care unit. Yes.
Okay, have you got any more final remarks or questions? No,
I don't know.
We've got 2 minutes. Well, I'd like to thank everyone for attending. I'd like to thank both of you for presenting a really interesting case, and for Irene for all your remarks. Thank you so much for coming onto the session today. We have 2 more episodes left of the mini series, and we look forward to seeing all the participants in the next one.